leading to. So we have, of course, our transplantations, and that transformed the landscape of the modern medicine. And it's providing hope and extending life. And that's where we all are doing our work for. So it's one of the most remarkable advancements in the modern medicine, and is asking a cooperation of different disciplines, just like we heard from Dr. Dolly. The lab needs to work with all the people, the clinicians, and whatever is involved in that transplantation. Of course, we have different types of transplantations. The one that we know the best is, of course, the autografts, where we are transferring tissue within the same person, or the allograft, where we are transferring organs or tissues between two subjects of the same species. Newer one, which are coming up, but still waiting for some comments, is the xenografts, where we are transferring organs between different species. Now, the common transplants we know are the kidneys, that's the most common one, followed by liver and heart. Now, how are we going? The best is we need to have the correct donor. So we need to find the correct match, like we heard already. What we see in the last years, or the last 20 years, is that, of course, due to the outcome of better immunosuppressions, which is, of course, preventing the recipient's immune system from reacting to the transplant organ, they are significantly improve the success of the rates of our transplant. But we all know we are still not there. We still see rejections. Now, the technological advances is, of course, the innovation in surgical techniques, organ preservation, and the immunosuppressive. That has made our, in the moment, the transplant safer and more successful. Now, what is the evolving technologies to detect HLA typing and HLA antibody detection? Because we all know we want to place a kidney, but we need to have the match. And then we are coming to the HLA polymorphistic system, which start to become bigger and bigger. Because with the new technologies on next-gen sequencing, we see the number of alleles increasing. We are sitting on 10,000, more than 10,000 B locus alleles already. So to find the real match is becoming really playing a game, because we need to be lucky to find the correct match. So what are the challenges? What we are facing at the moment is, of course, to find the correct donor. Are my slides not moving?
Slides are not moving.
Sorry. I maybe stop sharing and start sharing again.
Yeah.
You see it now moving? No?
Your slides are not shared yet, Christine. We do not see your slideshow.
You see it now moving?
No, not yet. We do not see your presentation. We can see you on the screen, but not your presentation. Okay, we can see your screen.
You see it now moving?
Can you change a slide, please? We can see the slide which says challenges, donor recipient matching, etc.
So you see it moving now?
No, we do not see the slide change.
You see the slides now?
Yes, it is the slide which says power of AI. If you want to change the slide, we can see whether the slides are changing. Okay, now they're changing. Please go ahead.
It's okay now?
Yes.
You see the full screen? Yeah.
We are not seeing it in full screen, but we can see your slides.
Yeah, but then I leave it like that because it seems when I put it on full screen.
That's okay. You can go ahead.
Yeah.
If you can,
okay.
You can change the slides and.
Yeah. So the challenges are, in fact, for the donor and the recipient matching. Where is the donor pool? Because we know it's becoming smaller. We need to find something more. Of course, we try to avoid still the chronic rejection, which we are knowing. And then, of course, what other challenges? Okay, the immunosuppressants are very good, but it's a long life treatment. And should we change all the same treatments for all the patients? So there is the power of AI coming in, which is computer algorithms, and it's containing machine learning or deep learning. And that is something which we use to complete the tasks that usually require human intelligence. Now, what is that AI in healthcare? So what we try to see is, can we use computer-based clinical decision support systems as a tool to improve our outcomes in healthcare by helping making the decisions with the assistance of clinical knowledge, patient information, and other health-related info. Now, be sure the final decision will stay by the clinician. Now, there are two things. You can use knowledge-based processes that are rules, which we know what we need to have. But the most important thing is non-knowledge-based process. That means statistics or machine learning or deep learning, where we enables the discovery of a complex structure in big data sets. Just like we heard from Dr. Dolly, we are getting like a lot of elements that we know that can play a role. The thing is, how are we going to put everything together to make our decision? Now, the machine learning is already used in a lot of healthcare. We see that there is like an increase in treatment protocol accuracy, where we are going to analyze patient information, create personalized treatment based on previous successful treatments. Also, when we look to the development of new treatments, we will need that machine learning. Pfizer used that technology already to accelerate their clinical trials when they were developing the COVID-19 vaccine. So let us go now to the potential for solid organ transplantation for AI. I mentioned here two articles which are recent, but which are giving you a very good overview. And the key areas where we can use AI in the transplantation will be in the management of the waiting list, in the molecular matching, which we heard already on, the transplant pathology, also in the immunosuppressive therapy, and in the personalized therapy. So when we go to a very easy one, we know that all the allocation systems are based on two major principles when we talk on disease donors. It's the expected outcome and the emergency. What we know is critical is the time that we needed to transfer our organ. Also there, we can start to use already our Internet of Things, where we over things can follow the whole organ transplantation so that everything can be already organized. It's a kind of AI already, which we can use and is used already. Then for the living donor, I mean, we find it also an article where the machine learning is even used in our daily life, and this to make the decisions important for transplant. This is where we evaluated how we, with AI-generated information, can promote, in fact, for people to perform or to be a donor, a living donor kidney patient. Now, when we go to the organ allocation, that is mainly connected to the donor-recipient mismatching. The traditional donor-recipient matching models leave room for improvement and could benefit from AI. And where are we using it already without we maybe realizing it? We know that the start of a new decade of matching came up with the development of the three-dimensional structure of HLA. Where we can see is where are those polymorphic residues, like we heard already in previous talks. When we go to that one, then we see that, for example, when we are talking on a polymorphic mismatch residue for a B51, then we see that that polymorphic thing is seen differently by different patients. Because here we see this typing, we'll see the B51 in a total different way than this typing with the B7 and the B8 will be seeing B51. So we are going now to a structural where we say, okay, instead of saying HLA-A, we are going to talk on a combination of different applets. And when we look then to a donor where we see the mismatch with the B18, because the patient was B7, so it's like a B mismatch, then we should say this is a fully mismatched. We cannot use that donor. But when we put the total HLA of that patient together with his other B allele and the A allele, then we see when we are looking to applets or epitopes that they are all together. I mean, there is no mismatch because they are all containing the same applet. And that is where we see that all those applet mismatches are going to influence really the de novo DSA, which is also, of course, one of the main reasons for a chronic rejection. Then, of course, besides those B cell epitopes, we know that also a T cell is like helping us because we cannot produce antibodies without having the help of our T cell. And also there we discovered now that those indirect recognizable HLA epitopes can play a role, because when there is already a high score, then we will have like much more risk to get antibody formation. And like we saw already before, also that PER scores will be influencing your survival. Now, when you look to this one, and now I don't have my animation, there are like two different articles which appeared that started to compare the HLA-B epitope scores and the HLA and the T cell epitope, the PERCH2. And we see then that when using those scores, we can make a risk analysis. Now, to be honestly, all those things, matchmaker, PERCH, HLA, EMMA, it are computational methodologies. So we are using machine learning already to see what this can bring to our B and T cell mediated alloimmune responses. And at the moment, we are looking more to the linked recognition, because both of them, scores B cell and T cell, will give us the possibility to make a risk stratification for our patients. Because high B cell score, high T cell score will give your patient a higher risk. When we go to lower scores, it will be a low risk. And we see that molecular mismatching activities are extending, because every day you can find new articles where it is giving that those things will give you a predictive accountable HLA compatibility. Now, also another part, pathology, which is also important, because what are we doing? We see an increasing of creatinine, we are going to do a biopsy, and also there AI is playing an important role. Because we see now commercial digital pathology slide scanners coming available. And we know our pathologists are very good and they can do it, but we are not having all over the best expert pathologists, or we are missing some. So also that algorithm will improve to give you a highly accurate comparison on the pathologies to make your decision that there is a rejection going on or not. There is also another thing. The AI is also already used in lung transplantation because there are AI systems that are looking to the lung matching in the lung transplantation. And that improved also the current standards. Now, what with AI and real-time adaptation of immunosuppressive? The protocol established early in 2000 remained largely unchanged. It improved the outcome of the transplant, we know that. But what? With immunosuppressive management, we can also use AI, because what is important that our patients are taking their immunosuppressive. We need to control it, because when they don't take it, we maybe can see a negative effect. But how do you know as a clinician that they are taking it? So what came up already were like automatic pill dispensers, which can control that the people are taking it and that you as clinician can have a control that they are doing in a correct thing. But what with all the immunosuppressive? Is that good? Yeah, maybe. But we see also a lot of adverse effect ranging from nephrotoxicity to melanges. It's giving you the reduction of life quality and life expectations, because we see more transplant people dying, transplant patients, due to the negative effect of immunosuppressive. And that is also where we are giving now more attention to. And we see alternatives coming up already. You have the molecular therapy, where you can see a depletion of alloreactive B cells by T cell, where we can do a CAR-T. We see also for the other ones, can we not use here CAR-T cells to targeting the B cells and giving that one instead of all those negative immunosuppressive? So that are all things that are moving. So what is the future for our transplant survivors? Previously, the current medicine is like one treatment fits for all the patients. This is not true, because we see for, of course, a lot of them, it's a giving you a positive effect, all those immunosuppressive. For other ones, it's no effect. And there are always exceptions where we see that those current medicines are giving a total adverse effect for the survival of our transplant. So what is the future medicine? Going to a more personalized diagnostics. That means with all the different tools we are getting now, non-HLA, HLA, molecular mismatching, all those different things which are coming up, we are taking that in account, also the whole personal information on your patient. And based on that one, with all that information, we should come to a personalized therapy so that we can help every patient and that the effect will be positive for everything. Now, honestly, this personalized medicine is nothing new. It was already described by Hippocrates 2,500 years old, years ago, and that was presented on the ESOT meeting in 2023 by Professor Nasus, who was so nice to provide me also his slides, where he said medicine is not absolute. This is a direction, cannot be generalized for everybody. Each human body is different and responds differently to therapy. Therefore, the same treatment cannot be suitable for everybody. It's really depending on patient individual characteristics, and that's where we need to go. But after 2,500 years, we are still using the common therapies. So with all the toolboxes that we have now inside, with HLA mismatching, HLA DSA, missing self, non-HLA, and all the diagnoses that we can do, what are we going to do it and how are we going to use it? Because this is too much to give us directly an indication what we as group need to decide, is this the correct one? So it's there where we need to go to the prediction of a therapy which is really personalized. And that is where also previously already was said, we need to take a risk in between brackets. We need that there are explicit degrees of uncertainty which we need to take in account and where we need to take the decision. So it's really urgent. We are taking a conceptual shift in how we integrate probabilistic reasoning in medical education. And in our field, we need to go to use the clinical decision support system effectively, which is also described in the article from Professor Nassen. And what we see here also is that just at the end of last year, also a group in the Netherlands received a huge money to invest to go to a personalized immunosuppression because we want to go for one kidney for a full life. We will hear about this project, which is called 𝑝𝑟𝑠𝑖𝑚𝑚, much more also. Because what they are looking to is like, we know what is causing patient death. It's side effects, infections, cancer. And what are the main causes of kidney transplant losses? It's T-cell mediated rejection, antibody mediated rejection, and fibrosis. So we need to go to something which is giving us a more personalized thing. And that's what he called it, the project 𝑝𝑟𝑠𝑖𝑚𝑚, which will start in June this year. And they are going to look to all different kinds of techniques. They will look to TCMR, ABMR, fibrosis, but looking also to the psychosocial and economic aspects, where everything will be included. Alloimmunity, HLA, biomarkers, pathophysiology, treatments and monitoring, because they want to come to a personalized immunosuppression. And this group you see is involved with different, not only from the Netherlands, but also Germany and people from Thailand will be indicated. We are looking really forward how this will give us indications what we need to use. Now, are there already systems available that can help us by the decision making with all those different things which we are getting at the moment on our platelet, like all those different diagnostic things, biomarkers, whatever we can see? Yes, there is a system already which is available, which is called iBox. And it's a first universal algorithm for predicting the risk of kidney transplant loss, which is developed by a group in Paris and which people are looking to already to use it. So the final tips and takeaways. Application of AI in solid organ transplantation is mostly under development at the moment. But we should target more comprehensive AI-based decision models, which include characteristics of all the different organs, because it's not for all the same, as well as patient-specific alternative therapeutic strategies. It will bring new insights to potentially enlarge the pool of the transplant organs and improve patient outcomes. Improvement of AI will lead to an increasing rely on AI as tool to support the decision-making process with human oversight, rather than it as a replacement of the physician, because there will always be their intervention that we will need. So thank you for all, and this is how we are going to be in the future AI, but be sure our brains will not be replaced by this system. Thanks a lot.
Thank you, Dr. Heylen. That was a very interesting and comprehensive talk. You have taken us through all the aspects of using AI, starting with evaluation of patient, allocation of organs, predicting graft survival, evaluating organ function, and then personalized medicine to be able to predict what outcomes are going to be and therefore use this resource very carefully. Thank you so much for your enlightening talk. You had actually mentioned technologies like ML, deep learning, and image analysis. Is there any role for large language models in these? I mean, these are especially what have come out in the last 1 or 2 years? Is there any applications looked at, given that there's such large variable data that is being evaluated?
Well, with that, certainly the group that developed that iBox, they were doing like larger studies. I mean, they were firstly internally in France, but they went also to the US. Now, what we see is indeed that is one of the limited things with giving us the, the good, or to be sure that we should use it, is that we need to do much larger studies, international, worldwide, and of course also to look to other organs, because at the moment everything is concentrated on kidney. So there is certainly a long way still to go. But of course we need to be, as transplant people, to open our minds to be involved in it. I think that's the first thing we need to do.
Sure. Dr. Nisha, do you have any comments, please?
Yes, sir. In the perspective of large language models and vision transformers and all, specifically if you want to get better accuracy in artificial intelligence, that area, we need a domain-specific model. So this domain is quite specific, right? So we need that much of massive amount of data to train that kind of domain-specific models also. That is one concern we researchers are facing.
Yeah, and I think for sure, because we all panic a little bit, AI or whatever, it's a black boxing. But like I said, it stays there that at the end, you can give, it can give you a tool, but it stays by the decision of the physician, because we still need like a human brain, which is overlooking it, to be sure.
Sure. So the take-home message is our horizons are expanding. There are many opportunities to be explored, but I think, as Dr. Nisha also mentioned, data is key to it. So I think collaborations to create clean data sets with clinic.
Yeah, for sure. Just like Dr. Dolly mentioned,
technology is the call of this.
The cooperation between all those different
multidisciplinary
technologies and everything need to be taken in account, and then maybe that AI can help us, but the decision stays in the group, for sure.
Sure.
Lucky for us that we are not replaced by a robot.
Yeah. Thank you, Dr. Heylen, for a very interesting talk. I'll hand it over to Dr. Antonio at the venue right now. Thank you.
Thanks a lot.
Thank you so much.
Thank you, Dr. Kristen Heylen, Dr. Joy John Mammen, and Dr. Nisha Varghese. I request all the participants to collect their certificates from the registration counter.
Next, we will be moving on to the most exciting segment of the day, the panel discussion.